Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find our previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. Today, we're discussing lung disease in systemic sclerosis, and we've invited Dr. Elana Bernstein, an expert clinician and researcher who has dedicated her career to improving patient outcomes for those with systemic sclerosis. We'll discuss the first symptoms that patients with systemic sclerosis develop, how the diagnosis is made, and explore the various ways in which systemic sclerosis affects the lungs, including pulmonary hypertension and interstitial lung disease. Dr. Bernstein describes her approach to screening for lung disease in patients with systemic sclerosis, as well as how she manages patients diagnosed with pulmonary hypertension and interstitial lung disease in a multidisciplinary scleroderma center. We'll finish our discussions with the latest research in the field and the questions that still need to be answered. Dr. Elana Bernstein is the Florence Irving Associate Professor of Medicine in the Division of Rheumatology at Columbia University Vagelos College of Physicians and Surgeons and Director of the Columbia University Scleroderma Center. She completed her medicine residency at the Massachusetts General Hospital and rheumatology fellowship at the Hospital for Special Surgery. Dr. Bernstein has received tons of funding, including from the NIH, the Department of Defense, the Rheumatology Research Foundation, and the Arthritis Foundation, all to study lung disease in systemic sclerosis. Enjoy. Elana, welcome to the show.
Thanks, John. I'm excited to be here. Thanks for having me.
Yeah. So how did you become interested in systemic sclerosis?
So back when I was a resident, actually, I was doing research on nephrogenic systemic fibrosis, or NSF. And so when I got to fellowship, it sort of seemed like a natural transition going from one fibrotic disease to another. I also found when I was a resident that I actually enjoyed taking care of people with pulmonary hypertension. I sort of found it very fascinating. We had treatments, they weren't fantastic. And, patients with systemic sclerosis have a high prevalence of pulmonary hypertension. So that also seemed to sort of come together for me.
Yeah, it's so funny how these chance encounters sort of helps to determine our profession. I remember when one of the first patients I ever took care of as an intern was this girl that presented with acute cardiopulmonary failure, and then was found to have pulmonary hypertension. And on exam, she had systemic sclerosis. I remember it was one of the first patients I ever took care of. And like you, I became so enthralled in pulmonary hypertension. And actually, I think one of the first presentations I gave to my MedPeds colleagues in our lunch didactics was about systemic sclerosis, because it was so interesting, so unknown. And, who knew that, I'd later pursue a career in rheumatology. So,
clearly meant to be.
It was meant to be. So tell me, I guess, hopefully we've learned a lot since you and I were both, interns and residents. Tell me how these patients typically present, because I imagine that, cardiopulmonary failure due to pulmonary hypertension may not be the most common presenting sign or symptom of patients with systemic sclerosis.
Right. And fortunately not.
Fortunately not.
So they often present much sooner than that. I think the issue is there can be a delay to diagnosis, because it can take, years before these patients make their way to a rheumatologist. They can sometimes languish for a bit of time. And so, patients can present very variably. So oftentimes Raynaud phenomenon is the first symptom, but that can occur, months, years, decades before any other manifestation. And so actually the way that we define disease duration in systemic sclerosis is time from the first non-Raynaud symptom. And that's because the Raynauds can occur such a long time before the rest of the symptoms. But people can have puffy hands, hand stiffness. They can start with skin thickening as a first manifestation as well. Some people might notice some telangiectasias crop up. But I would say, puffy hands really are one of the more common presenting symptoms of scleroderma.
And in patients that start developing symptoms of scleroderma, what type of doctors are they typically referred to before they land in your office?
So, sometimes they start, oftentimes I would say, with a primary care doctor, but sometimes it's, urgent care as well.
Mm,
Like people can present with a digital ulcer
mm.
that they might think it's infected, go to urgent care. But oftentimes they'll see, if they have a primary care doctor, they'll see the primary care doctor. And, that's really the critical time for that primary care doctor to sort of think, even if not of systemic sclerosis, of something autoimmune going on. And that's oftentimes when an ANA will be checked. And
Mm.
then perhaps some additional, ENAs. And then hopefully these patients then make their way to a rheumatologist.
Got it. So in a patient that's presenting with symptoms like Raynaud's, certainly digital ulceration, puffy hands, thickened skin, telangiectasias, these are people that should be screened for systemic sclerosis.
Oh, absolutely. I mean, that constellation of symptoms you mentioned right there, that would be, virtually a slam dunk for a systemic sclerosis diagnosis.
Got it. So when you see these patients referred to you in clinic, how do you actually establish the diagnosis? Is it sort of, do you just go by clinical findings? How much do you rely on the autoantibodies?
Autoantibodies are certainly part of it, but not the entire story. Just like really most or all of our diseases, the diagnosis isn't made by an autoantibody alone. It's really a constellation, clinical manifestations, serologies, things like that. So the way I make the diagnosis is by doing a complete history and physical examination, obviously looking very closely for evidence of systemic sclerosis. So I'm doing, a modified Rodnan skin score, examining the hands, looking for ischemic and traumatic digital ulcers, for acrosteolysis, digital pitting scars. I do nail fold capillaroscopy to look for, dilatation and dropout of nail fold capillaries. Auscultating, obviously, the heart and the lungs. I'm listening for crackles on the pulmonary exam. I'm listening for an accentuated pulmonary component of the second heart sound. When I'm sort of thinking about, could this patient have pulmonary hypertension? I'm looking for any evidence of lower extremity edema. So it's really a very, thorough exam, looking also for telangiectasias, calcinosis, really anything that you might see in systemic sclerosis, as well as, of course, like synovitis, things we look for sort of in all of our patients. And then I do, a full serologic evaluation. In these patients, we're usually most interested for sure in, their ANA, and then the three most common systemic sclerosis autoantibodies, the, SCL70, centromere, and RNA polymerase 3. If those are negative, I tend to send a more extensive SSC panel. But it's really all of this together that helps make the diagnosis.
It's so interesting to hear you explain about the physical exam, because I often feel like, in the 21st century, like the physical exam there's less emphasis on it. And one of the things that always excited me about rheumatology is that we still need we're the detectives, right? And looking at the nail fold capillaries, or looking, for telangiectasias in the chest, and all these subtle findings that other people can miss can really, make or break the diagnosis of systemic sclerosis, for instance.
Oh, absolutely. And I think it all starts, when I greet the patient in the waiting room. I'm shaking their hand and kind of taking it all in. And sometimes you can tell sort of right away, shaking someone's hand, you can tell by the appearance of the fingers, the rest of the hand, that this is a scleroderma phenotype.
Wow. And within scleroderma, are there the two classic phenotypes? Is that still hold water? The sort of the diffuse and the limited?
I mean, yes and no, right? There's diffuse, there's limited. There's also CNA scleroderma, which is, systemic sclerosis without skin thickening, and those people sort of cluster along with the limited cutaneous subtype. But I think even more relevant than that division is the autoantibody phenotypes. I think these different autoantibodies really have particular clinical associations that can be very informative when taking care of patients and sort of trying to give them a sense of what might happen down the line.
So tell me a little bit more about that, and how do you look at the antibodies and then help to predict sort of, the various disease manifestations?
Sure. So, we know that the anti-centromere antibody, for example, is more commonly associated with the limited cutaneous subtype, and that it has a clear association with the development of pulmonary arterial hypertension, for example, and also digital ischemia. We know that the anti-SCL70 or anti-topoisomerase 1 tends to be more associated with the diffuse cutaneous subtype and is also associated with the development of interstitial lung disease and of progressive ILD. So these are, patients who I'm keeping a very close eye on for the development of ILD and also for the progression of ILD, as time goes forward. And then the RNA polymerase 3 antibody is actually also very interesting. It has a lot of clinical associations. So it's associated with rapidly progressive skin disease. So these are patients who, could come in, I meet them, for the first time and their skin score is let's say a 4, nothing major and in a limited distribution. But I see them back in 2 months and their skin score is a 20 something.
Wow.
And then 2 months later, it could be in the 40s. So very rapidly progressive. It's also associated with GAVE or gastric antrovascular ectasia. So I know that if I see that these patients are anemic and if they're iron deficient, especially, I'm going to refer them very quickly to GI for an upper endoscopy to look for GAVE and to treat it. They're also, this RNA polymerase 3 antibody is also associated with renal crisis. So while I have all of my scleroderma patients check their blood pressure at home to monitor for renal crisis, I'm, keeping a very close eye on these patients. And the other very interesting manifestation with this RNA polymerase 3 antibody is malignancy. They've actually done studies, and a lot of this work has come out of Johns Hopkins, where they've identified the RNA polymerase 3 antigen and tissue from solid tumors. So in this subset of patients, obviously I want all of my patients to be current with their age-appropriate cancer screening, but I'll do even more of a malignancy evaluation in these patients who come in with new onset scleroderma and an RNA polymerase 3 antibody.
So like a CT chest, abdomen, pelvis, or what?
Yeah, it's, everyone's going to get a chest CT anyway to screen for ILD. But yeah, I would also do a CT of the abdomen and pelvis, obviously making sure they're up to date with Roman mammogram, colonoscopies, certainly if they're 45 or older, but even if they're younger, I would encourage them to get a colonoscopy. And then I'm also doing oftentimes thyroid ultrasounds in these patients. And then for women, pelvic ultrasounds to try to get a look at the ovaries, and in men doing scrotal ultrasounds.
Interesting. For testicular cancer?
Yeah.
Amazing. Do these antibodies ever overlap, or are they pretty separate?
They can overlap. I think for a long time it was felt that they're mutually exclusive. And I think most often they are, but not always. And certainly, if you're doing just sort of a bead assay or an ELISA and you're testing multiple antibodies, you might have some that come back with very low titers, for example, like a centromere of 1.2, 1.4, but then, an SCL70 titer is greater than 8. Well, I think in that case, that centromere antibody is probably a false positive, whereas the SCL70 is real. But I certainly have patients who have very high titers of more than one of these antibodies. There are very few of them, but it can happen.
It's so interesting how you mentioned that you rely more on the antibodies than sort of on the way that they present to prognosticate patients. It reminds me a little bit of ANCA-associated vasculitis. in that, I remember trying to struggle. Is it like GPA? Is it MPA? Is it eGPA? But many of the studies have found that it's more important to look at, is it PR3 ANCA or
Hmm.
MPO ANCA to help predict prognosis and disease manifestations.
Yeah, absolutely.
And I guess also with myositis, right? Depending on which myositis autoantibody you have, certain risk factors for development of disease, and some are easier to treat than others, and some have better or worse prognoses.
Oh, yeah. No, absolutely. When I see someone with an anti-synthetase antibody, I'm very clued into the, potential development of interstitial lung disease if they don't already have it. If I see an MDA5, same thing.
Yep.
I'm very concerned that they're going to progress rapidly.
Yeah, yeah. Interesting that we're, even though we're focused a lot on the physical exam, we rely on these laboratory markers to help sort of prognosticate patients and put them in buckets, so to speak.
Yeah, they're very helpful.
Yeah, let's talk a little bit about the lungs in systemic sclerosis. What are the ways in which patients can develop lung disease when they have systemic sclerosis?
Sure. So, probably the two most common pulmonary manifestations in systemic sclerosis are interstitial lung disease and pulmonary hypertension, which, and the pulmonary hypertension may be pulmonary arterial hypertension or PAH, or it might be, you know, just pulmonary hypertension due to, let's say, interstitial lung disease or to left-sided heart failure or chronic pulmonary emboli or something like that. I think patients can also get small airways disease, which is, I think, under-recognized in systemic sclerosis. They can get pulmonary veno-occlusive disease, which is sort of a subtype of pulmonary hypertension that's more difficult to treat. But really, from the rheumatologist perspective, the two main manifestations that we think about in patients with systemic sclerosis regarding the lung are ILD and pulmonary hypertension.
Okay, and as you mentioned before, those with centromere antibodies are more likely to develop the pulmonary arterial hypertension, whereas with the SCL70, those patients are at higher risk for ILD.
That's right. And that doesn't mean that people who are SCL70 positive can't get PAH. They absolutely can. But those with a centromere antibody, I think, are more likely to get PAH. And, there are other antibodies also that, we see in systemic sclerosis that are associated with PAH. And those include a U1 RNP, and also having a positive ANA and a nucleolar pattern can be associated with the development of PAH.
So in that patient that you saw, you greeted in clinic and you diagnosed with systemic sclerosis based on the clinical exam and the labs. How do you screen for both ILD and pulmonary hypertension?
Pulmonary function tests are critical to perform when screening for, both interstitial lung disease and pulmonary hypertension. So we often look at spirometry, which is one component of the PFT, and the main parameter there that we're interested in is the forced vital capacity, or FVC. And a significantly reduced FVC, really should clue you into the presence of interstitial lung disease. The diffusion capacity for carbon monoxide or DLCO is another parameter that we're very interested in when we're screening for interstitial lung disease and pulmonary hypertension. So the DLCO can be reduced in both interstitial lung disease and pulmonary hypertension. But in pulmonary hypertension, the DLCO tends to be reduced out of proportion to the FVC. So a reasonable cutoff to use is the ratio of FVC to DLCO. And the ratio of FVC to DLCO of greater than 1.6 should raise suspicion for the presence of pulmonary hypertension. Obviously, it's not diagnostic for it, but it should make you think about it.
Okay.
And also a decline in DLCO over time. So over, serial PFTs that show a progressive decline in the DLCO are really another clue to the development of pulmonary hypertension. Another test that we use to screen really specifically for pulmonary hypertension is the echocardiogram. It's a two-dimensional echo with Doppler. And there we mainly look at the pulmonary artery systolic pressure. So an elevated PASP, pulmonary artery systolic pressure, again, is another clue that someone has pulmonary hypertension. But people can have a normal echocardiogram, can have a normal PASP, and still have pulmonary hypertension. So if there's any concern that someone has PH, they really need to go for a right heart catheterization for diagnosis. And the one other screening test that's really important for screening for interstitial lung disease is the high resolution non-contrast chest CT. And I strongly believe that all patients with systemic sclerosis should have an HRCT at baseline when they're diagnosed with systemic sclerosis to screen for ILD.
Got it. So when you get your patient, you just diagnose them, you immediately order PFTs, echo, and a high-res CT?
Yes, absolutely.
Okay. Amazing. Do you have any clues as to, first, like, why patients with systemic sclerosis, like how the disease manifestations come about? Like, why are patients getting, skin fibrosis, pulmonary arterial hypertension? It's certainly an autoimmune disease, but do you have any sense of like what's happening inside the body that's causing, all of these things to occur?
Oh, that's the $1,000,000 question. We know that there's this interplay between fibrosis, vasculopathy, and inflammation and autoimmunity. I suspect that endothelial injury and microvascular damage are really the ultimate or sort of the initial precipitants of systemic sclerosis that sort of eventually lead to all of the other complications. But there's just so much we don't know.
It's incredible. I mean, that's one of the reasons why I became interested in rheumatology, is that there's all of these questions that we don't know, and like the mystery of these diseases is so interesting. And to have people like you that are working to help figure it out is really encouraging.
Oh, thank you. There are many, many others.
Yes, yes, and we've had many of those people on our podcast as well. So let's talk a little bit about treating patients with systemic sclerosis in general, and then we can focus a little bit more about how you manage their lung disease. So are there certain therapies that you think patients with systemic sclerosis should be offered? Or do you go by, whatever signs or symptoms that they're presenting with?
Yeah, it's really based on what organs, if any, are involved. So, unfortunately, there's no overall disease-modifying therapy for systemic sclerosis like there is in rheumatoid arthritis, where, we tend to give methotrexate to patients who are newly diagnosed with RA, and that, really is first-line therapy. If I had to say, like, what is first-line therapy for systemic sclerosis, I would say that's, mycophenolate, mofetil, or MMF, but that's only if someone has significant skin thickening or interstitial lung disease. So if there are patients who are diagnosed with systemic sclerosis, for example, because they have Raynaud's and a centromere antibody and some telangiectasias and abnormal nail fold capillaries, but there's no reason to give those patients immunosuppressive therapy. So it really depends on what, if any, organs are involved.
Got it. So let's talk a little bit about Raynaud's. What's your favorite treatment for Raynaud's in patients with systemic sclerosis?
Favorite. I would say, first line therapy would be a calcium channel blocker.
Okay.
One of the dihydropyridines. So amlodipine or extended release nifedipine. That said, they're by no means a panacea. So, we think that they're doing something, on sort of the microvascular level, but patients might not, clinically experience a benefit from them. So if they have Raynaud's, really severe Raynaud's, or if they have Raynaud's with digital ulcers, then I have a very low threshold to add a second agent, which is usually a phosphodiesterase 5 inhibitor or PDE5 inhibitor, such as sildenafil. And obviously, lifestyle measures are really important for people with Raynaud's. So avoiding the cold, which is hard to do where I am in New York City and where you are in Boston, right? Not very practical. I've certainly had patients move to Florida for their
Nice.
Raynaud's, but even, during the summer or in a hot climate like Florida, the air conditioning can be a trigger. So it's very important for people to keep their core warm, to always have, gloves or mittens available, hand warmers if necessary. Stress we know, is a trigger for Raynaud's, but stress reduction is probably easier said than done for many people. And then smoking cessation is critical. So, smoking is bad for so many reasons. And one of those reasons is Raynaud's. So if there are patients with scleroderma who smoke, they should absolutely not.
And for Raynaud's, do you sometimes vary the medication depending on the time of year? Like if it's the summer, take patients off of amlodipine, for instance, and then start it back up in the fall and winter? Or do you generally, once you start it, you keep the medications year round?
So, I mean, generally speaking, I will keep them on it year round, but I do have some patients who prefer to either lower the dose, especially those who are, let's say, on a combination of a calcium channel blocker and sildenafil. They'll either want to stop the sildenafil or lower the dose during the summer, and I'm absolutely fine with that. Then there are patients I have who have such severe Raynaud's and digital ulcerations that they need epoprostenol, and they actually come in and get admitted to one of our ICUs so they can actually get 5 days of epoprostenol. So, and sometimes in people who we know develop very severe ulcers, during fall and winter months, we'll actually have them come in, end of summer, very beginning of fall, sort of prophylactically for epoprostenol.
Oh, fascinating. And for people that don't have ulceration, is the reason to treat the Raynaud's purely symptomatic? Like, do you think, if the patients have Raynaud's and it doesn't bother them, that then it's not worth treating? Or do you think that every time that they're getting an episode of Raynaud's, there's some damage being done to the fingers or to the vasculature?
That's a really great question. And I think in a perfect world, we would have treatment that's really good for Raynaud's, that anyone who had Raynaud's in the setting of systemic sclerosis could take it and it would be helpful and it would prevent any potential damage down the line. Unfortunately, we don't have any medications like that. So given that I don't really think calcium channel blockers work like extremely well for Raynaud's, I'm okay if someone has Raynaud's, has never had digital ulcers, and it doesn't really bother them and they don't want to take a medication for it. I'm okay with that. Patients who have severe Raynaud's, I would say, they're better off being on something than not.
Okay. Makes sense. So now let's turn to the lungs. You hinted a little bit about your treatment for ILD. So let's say you get the high-res CT and it shows some element of ILD. Are there thresholds for starting medications? I know that, sometimes my pulmonary colleagues say it's like, yeah, there's some ILD on imaging, but the patient is asymptomatic and the PFTs are good. So, maybe they don't need treatment at this time. What are your thoughts? Like, what's your threshold to start somebody on immunosuppressive therapy for ILD?
So that's a great question. I don't have a threshold that's sort of written in stone, for everyone. For me, everything is on a case-by-case basis and joint decision-making with the patient. I would say if someone has ILD on their HRCT, I'm often inclined to treat, assuming the patient is willing, but I take into consideration, other risk factors they have for progressive disease. So, for example, if someone is SCL70 positive, if they are of African descent, if they are of male sex, we know that these are all risk factors for progressive ILD. So even if the ILD that's detected on screening HRCT is very mild, I'm going to have a discussion with that patient about their risk factors for progressive disease, and I would recommend usually starting therapy. If there's someone, for example, who on their baseline HRCT has very minimal interstitial lung disease, who's centromere positive and limited, and they really don't want to take medication for ILD, then we can certainly do, very close monitoring. Some people will say that, some people will say that centromere antibody is sort of protective against progressive ILD. And I think by and large, that's that's probably true that people with central antibody positivity are less likely to have progressive ILD. But that doesn't mean that there aren't people who are centromere positive who have progressive ILD, right? So you have to think about the patient sitting in front of you when making these recommendations.
Got it. So what's on your treatment menu? What medications are you using to treat ILD?
So typically, MMF, I see it as first line therapy.
Hmm.
Other options, I think, in patients who are progressing despite MMF are tocilizumab, rituximab, nintedanib. Those are sort of the big ones that I think about adding to MMF if someone has progressive SSc-ILD.
So let's say you get a CT scan that shows ILD, you start a patient on MMF. When are you doing your next CT scan to see if it's progressed or not?
I don't make that decision up front. I monitor their PFTs very closely.
Oh,
So
okay.
in someone with a new diagnosis of ILD, I'm usually going to get PFTs every 3 months, maybe every 3 to 4 months for the first
Okay.
few years. And if their FVC is declining, if they develop new symptoms or worsening symptoms, then I'm going to, repeat a chest CT to see if there's radiographic progression.
Hmm. Okay. Great. So basically you use the patient's symptoms and the PFTs as a proxy to figure out what may be going on in the lungs.
Absolutely. Yeah.
Okay. Do you ever get surprised that, patient seems to be doing well, PFTs are stable, and then you get a CT scan that shows, significant progression? Or is that a pretty good way of screening, a pretty effective way of screening patients?
I think it's pretty effective for monitoring, but I think we certainly need to know more about the utility of serial HRCTs in SSc-ILD. We don't know how often really we should be repeating them, if we should be. I mean, yes, at some point people should have a repeat HRCT if they have interstitial lung disease. Whether that should be annually in everyone, whether it should only be done with, worsening symptoms or declining PFTs. We don't have great data.
And what about pulmonary hypertension? How do you manage that? So I guess these are the patients that you screen with an echo. It may shows, perhaps elevated pressures, and then you send them for a right heart cath that confirms pulmonary hypertension.
Yeah. So it's really important to work very closely with a PH specialist in patients with systemic sclerosis who have pulmonary hypertension. So if I suspect that one of my patients has pulmonary hypertension, I refer them to one of our PH specialists before right heart cath because I want their
Okay.
opinion and I want them, to weigh in about whether they think a right heart cath is necessary or not. And if a patient has a right heart cath and the diagnosis of PH is established, then the treatment is really directed by the PH specialist. So typically, patients who functional class 2 or worse symptoms are treated often with combination therapy, from medications from at least two classes. So the major pathways that are targeted by our PAH medications are sort of the endothelin 1 pathway, the nitric oxide pathway, and the prostacyclin pathway. So oftentimes, two medications, one from one class, one from another, are given upfront to patients who functional class 2 symptoms or worse. But sort of
Got it.
which medication is really determined by the PH specialist, who might be, depending on institution, might be a cardiologist or might be a pulmonologist. It's very institution dependent.
Got it. And that brings me to a question about like, what does the team look like that manages a patient with systemic sclerosis? Because as you've hinted, systemic sclerosis can affect the skin and the lungs and the GI tract and the heart. So, what does your scleroderma program look like? And how do you coordinate the care of patients with systemic sclerosis?
Yeah. So oftentimes physicians from multiple different specialties are involved. And it really depends on what organ systems are involved for a given patient. So If someone has interstitial lung disease, they're often also seeing one of our ILD specialists.
Hmm.
If they have PH, they're of course seeing one of our PH specialists. I have a very low threshold for referring to our GI motility colleagues because a lot of our patients just have severe GI disease that is very, very hard to manage. I think, those are the main specialties I would say that are involved in the care of our patients. And, for other manifestations, of course, we involve other specialties as needed.
How do you think about treating the skin disease in patients with systemic sclerosis?
So that's a good question. Right now, I would say, our medications for skin are not fantastic. I Again, I see MMF as sort of first line therapy. So how do I see it? It's immunosuppressive therapy. And I'm talking about patients who have, significant involvement of skin. There are certainly patients who have, let's say, the limited cutaneous subtype, who might have a little bit of thickening of the fingers and the hands, maybe the feet, but it's not necessarily bothering them. It's not progressing, and it's not resulting in disability. Like they're not developing finger contractions or things like that. In those patients, I'm typically not going to prescribe an immunosuppressant to treat that. And many of those patients don't want to take an immunosuppressive therapy for sort of minimal skin thickening. But in someone who has more significant skin thickening, generally speaking, I start with MMF. If they're continuing to progress, then, I think about adding other agents and or enrolling them into a clinical trial. And the same thing actually for interstitial lung disease. If someone has progressive SSc-ILD, at the same time I'm thinking about adding an agent, I'm also thinking about what clinical trials are available and what makes more sense. Adding an agent, that we know right now, or putting them into a trial. And what do they want?
Got it. And how often, or what's the typical prognosis for patients with either PAH or ILD? Once you start immunosuppressive agents, do things stay the same? Do things get better? Or do you just try to slow the progression of the underlying disease?
So for, ILD, I would say right now, with medical therapy, our goal is to stabilize the disease, to try to prevent progression. To my knowledge, the only treatment out there that has resulted in improvement in lung function is stem cell transplant that has resulted in improvement of ILD. I mean, obviously lung transplant, of course, results in that too, but stem cell transplant, which is, a procedure that has significant morbidity and, some associated mortality with it. So, but in terms of medical therapy alone, at this point in time, sort of, I think the most that we hope for is stabilization. Obviously, I would love to get to a point where our medications actually result in improvement in symptoms.
And how about for pulmonary hypertension?
So for pulmonary hypertension, I think we're looking for symptomatic improvement, better exercise tolerance, things like that. Unfortunately, not everyone responds well to therapy. And in patients who don't respond well to therapy and who continue to progress with their pulmonary hypertension, then it's really important, I think, to counsel them early about lung transplantation and refer them early for lung transplant evaluation at an experienced center.
Got it. And what are those clinical trials that you hinted at? What sort of medicines are being tested for patients with systemic sclerosis and lung disease?
So there are several actually. So the one of the really exciting studies out there, I think right now, is the Conquest study. I don't know if you've heard of it, but it's sponsored by the Scleroderma Research Foundation, and it's the first ever platform clinical trial in the scleroderma space. So
Wow.
platform clinical trials have been around for a while really in the oncology space. And I think a platform is a great way to move science and scleroderma forward. So that's one. We also
So tell me more about what a platform study is.
Right. So it's basically in a platform. So in clinical trials, you go through all this effort to come up with a budget and contract and to get all the pieces in place to do a trial, and then the trial ends and all that goes away. So in a platform trial, what it does is a few things. One, it creates this infrastructure for a trial. So you only do startup once. So you go through all the contracting procedures, and then once the trial is up and running, the platform continues. And what you do is you bring in different investigational products at different points. So it allows you to test multiple medications or investigational products sort of simultaneously. And what that does is it lets you do a shared placebo group. So ultimately, you need to recruit fewer participants because you don't need to recruit a separate placebo arm for each medication that's being tested in the platform. And then, for example, once, let's say you're testing 2 medications and those, you've done your 6-month, 12-month trial, however long, and that trial ends, you can bring in another 2 or 3 medications into that platform and you continue going, and you don't need to recontract and reestablish the infrastructure.
Super cool. So I imagine that there are several centers, like scleroderma centers, that are part of this platform and that all sort of work together to have the same clinical trials and recruit patients and whatnot.
Yeah, this is actually a global platform.
Global. Wow. Amazing.
Yeah. So it's very exciting. And there's also, there are several CAR-T trials that are in various stages of startup for systemic sclerosis, which is, very exciting. So we'll see. The jury's still out, of course, but that's why we're doing the studies.
Amazing. What do you see as the future of systemic sclerosis treatment?
That is a really good question.
I only ask good questions, Elana. I don't know if you've noticed.
The future of systemic sclerosis treatment. I mean, I see a future, ideally, where we have effective therapies that do more than just stabilize disease, but actually result in improvement in clinical outcomes and in how patients feel and how they, function, because that's really what we care about. And I see, taking hopefully more of a personalized medicine approach to patients where, a patient comes into the clinic, we, very extensively clinically phenotype them. Hopefully we've identified some biomarkers that are, predictive of response to certain therapies, and we can identify which therapy would be best for a given patient.
Yeah, and I think that goes very well, I guess, to all of the other diseases that we manage as rheumatologists, is that we're trying to figure out what is the best medicine for this particular patient. And I would love to see us do a better job in getting patients better, like you mentioned, and not just stabilize disease. But I guess, we have to start somewhere. And Elana, what are the big questions that still need to be answered in the systemic sclerosis space?
Yeah, I think the jury is still out on the use of immunosuppressive therapy to treat systemic sclerosis associated PAH. So, we had several years ago, there was the rituximab trial for SSC PAH, and it didn't meet its primary endpoint. It was a difficult to enroll study. So the primary endpoint was changed, and there was no improvement in 6-minute walk test at 24 weeks, which was the new primary endpoint, but there was improvement at 48 weeks. And then, in a post hoc analysis, it was found that patients who had low levels of rheumatoid factor, IL-2 and IL-17 had a pretty impressive response to rituximab. So I think there are some patients with SSC-PH who actually might respond very well to at least rituximab. I don't know about other immunosuppressive therapies, but I don't think we have a great way of determining, short of running these, biomarker assays of who those patients are. So, I hope that at some point there will be future trials of immunosuppressive therapy for SSC, associated PAH, because I think obviously vasodilators are critical, and that's what we have now in our armamentarium. But I think it's still an unanswered question about the role of immunosuppressive therapy for SSC PAH.
Yeah, again, we started with the mysteries of, these patients that develop pulmonary hypertension, and it's a great way to close this episode with, with the mysteries and whether, immunosuppression may help patients with systemic sclerosis associated PAH. Elana, this has been a really engaging and fantastic and interesting discussion. I thank you so much for your time and for everything that you're doing for patients with systemic sclerosis.
Oh, thank you, John. It was really delightful to be here today. It was a lot of fun.
So there you have it. Everything you ever wanted to know about lung disease and systemic sclerosis, but were afraid to ask. Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find our show notes for this and other episodes at acronair.org, on Apple Podcast, Spotify, and on your favorite podcast app. Until next time, keep screening patients for lung disease. And of course, stay healthy.